Pediatric devices. Pediatric devices and equipment. Welcome. Welcome to PediaTime's Pediatric Devices and Equipment Reference. Overview. This comprehensive resource provides detailed information on pediatric medical devices and equipment organized by body systems, with proper usage protocols, sizing charts, and troubleshooting guidelines. How to navigate. Select a system category above to begin exploring pediatric medical equipment. System categories. Light bulb tip. Each equipment entry includes pediatric specific size charts, troubleshooting guides, top tabs, equipment organized by body system, CVS, respiratory, CNS, etc., plus general categories. Sidebar. Select specific devices to view detailed specifications and usage guidelines. Select a system category above to begin exploring pediatric medical equipment. System categories. Cardiovascular, ECG monitors, defibrillators, pacemakers, cardiac output monitors, ECMO equipment. Respiratory, ventilators, oxygen delivery systems, suction devices, airway management tools, nebulizers. Neurological, ICP monitors, EEG machines, cooling devices, neurostimulation equipment. Renal, light bulb tip. Each equipment entry includes pediatric specific size charts, troubleshooting guides, safety protocols, and evidence-based best practices. ECG monitors. Overview. Electrocardiography (ECG) monitors are essential cardiovascular diagnostic devices that record the electrical activity of the heart. In pediatric care, ECG monitoring requires specialized knowledge of age-appropriate norms, proper lead placement on smaller body surfaces, and interpretation of developmental cardiac electrical patterns. Warning: key pediatric considerations. Pediatric ECG interpretation differs significantly from adults due to age-dependent variations in heart rate, axis, intervals, and normal physiologic variants that may mimic pathology in adult tracings. Types of pediatric ECG monitors. 1. Continuous bedside monitors. 3-lead monitoring, basic rhythm monitoring, limited diagnostic capability. 5-lead monitoring, enhanced rhythm and ST segment analysis. 12-lead continuous, comprehensive monitoring in critical. Three-lead monitoring, basic rhythm monitoring, limited diagnostic capability. 5-lead monitoring, enhanced rhythm and ST segment analysis. 12-lead continuous. Three-lead monitoring, basic rhythm monitoring, limited diagnostic capability. Two. Diagnostic ECG machines. Standard 12-lead, comprehensive diagnostic evaluation. 15-lead ECG, includes right-sided leads V3R V6R for right ventricular assessment. Standard 12 lead, comprehensive diagnostic evaluation. 15 lead ECG, includes right-sided leads V3R V6R for right ventricular assessment. 18 lead ECG, adds posterior leads V7 V9 for posterior wall evaluation. Standard 12 lead placement. Light bulb tip for right arm. Right upper chest, shoulder. Below clavicle, may use smaller electrodes. Left arm. Left upper chest, shoulder. Below clavicle, avoid breast tissue in adolescents. Left leg. Left lower abdomen. Above iliac crest, symmetric to RL. V. V1. Fourth intercostal space. Right sternal border, reduced spacing in infant. V2. Fourth intercostal space. Left sternal border. V3. Between V2 and V4. Halfway point, adjusted for body size. V4. Fifth intercostal space. Midclavicular line may be more medial in infant. V5. Fifth intercostal space. Anterior axillary line. V6. Fifth intercostal space. Mid-axillary line. Light bulb tip for neonates, infants. Precordial leads may need to be placed in a smaller, more compressed pattern due to smaller chest size. Document any modified placement for accurate interpretation. Modified lead placement for specific conditions. Age-specific normal values. Values. Heart rate, beats per minute. ECG. Dextrocardia suspected. Mirror image placement, right-sided. Appropriate axis for anatomic variation. Congenital heart disease. Right-sided leads, V3R, V6R. Assess right ventricular hypertrophy, strain. Posterior me suspicion. Posterior leads, V7, V9. Detect posterior wall ischemia, infarction. Brugada screening. High precordial leads, 2nd, 3rd ICS. Enhanced detection of Brugada pattern. Filter mode selection. Diagnostic mode 0.05-150 Hz for 12-lead diagnostic ECGs, preserves all waveform details including ST segment. Monitor mode 0.5-40 Hz for continuous bedside monitoring, reduces artifact and baseline wander. Surgery mode 1-20 Hz, maximum artifact reduction in OR environment. Equipment Setup Protocol. Preparation Steps. 1. Skin preparation. Clean skin with alcohol wipe, allow to dry completely. For oily skin or poor adhesion, use abrasive prep pad gently. Remove excessive hair if necessary, adolescents, clip, don't shave. Ensure skin is dry and free of lotions, oils. 2. Electrode selection. Neonates, use neonatal electrodes 22-25 mm diameter. Infants, toddlers. Pediatric electrodes 30-35 mm. School age and up, standard adult electrodes acceptable. Check expiration date, expired electrodes have poor adhesion. 3. Application technique. Peel backing immediately before application. Apply with firm pressure, smooth from center outward. Ensure complete contact, especially gel center. Avoid placing over bony prominences or muscle groups. 4. Lead wire connection. Snap connectors firmly to electrodes. Create strain relief loop to prevent tension on electrodes. Secure cables to prevent patient entanglement. Common artifacts and troubleshooting. Hz interference. Regular fine oscillations. Electrical interference, poor grounding. Check ground lead, unplug unnecessary equipment, replace electrodes. Baseline wander. Slow undulation of baseline. Patient movement, respiratory effort, poor electrode contact. Reposition, replace electrodes, ensure proper adhesion, adjust filter. Muscle tremor. Irregular rapid oscillations. Shivering, muscle tension, crying. Warm patient, calm, sedate if appropriate, reposition limb leads to trunk. Lead reversal. Abnormal axis, inverted waves. Incorrect lead placement. Verify lead positions, check color coding, reapply correctly. Lead off. Flat line or extreme artifact. Loose electrode, disconnected lead. Check connections, replace electrode, ensure gel contact. Movement artifact. Irregular large deflections. Patient movement, cable motion. Secure cables, minimize patient handling, use appropriate sedation. Poor R wave. Small QRS amplitude. Improper lead selection, electrode position. Change monitoring lead, verify V1 placement, adjust gain if needed. Clinical indications for ECG monitoring. Continuous monitoring indications. Critical care patients, ICU, post-operative cardiac surgery, hemodynamic instability. Arrhythmia surveillance, known or suspected rhythm disturbances, syncope evaluation. Medication monitoring, court prolonging drugs, antiarrhythmics, chemotherapy. Procedural sedation, during and after sedation, anesthesia. Acute cardiac conditions, myocarditis, pericarditis, chest pain, Kawasaki disease. Metabolic derangements, severe electrolyte abnormalities, especially potassium, calcium. 12-lead diagnostic ECG indications. Chest pain, suspected ischemia, rule out myocardial infarction, rare but possible. Syncope, pre-syncope, evaluate for conduction abnormalities, long court. Palpitations, document baseline rhythm, assess for pre-excitation. Congenital heart disease, initial evaluation and follow-up. Inflammatory conditions, myocarditis, pericarditis, Kawasaki disease. Family history screening, sudden cardiac death, cardiomyopathy, channelopathies. Pre-participation sports physical, consider in high-risk populations. Medication monitoring, baseline and follow-up for cardiotoxic medications. Metabolic disorders, electrolyte abnormalities, endocrine disorders. Critical ECG findings requiring immediate action. Revolving light immediate intervention required. Ventricular fibrillation, pulseless VT, begin CPR, defibrillate immediately. Complete heart block, prepare for pacing, notify cardiology. Symptomatic bradycardia, consider atropine, prepare for pacing. Unstable tachycardia, synchronized cardioversion if hemodynamically unstable. Significant ST elevation, rule out acute coronary syndrome, myocarditis. Extreme QTC prolongation greater than 500 milliseconds, risk of torsades, stop offending agents. Pediatric specific ECG patterns. Normal variance, not pathologic. Right axis deviation, normal in neonates, infants, up to plus 110 degrees to plus 180 degrees. Right ventricular dominance, tall R waves in V1, deep S in V6, normal up to 1 to 2 years. Juvenile T wave pattern, inverted T waves V1, V3, normal until adolescence. Sinus arrhythmia, heart rate variation with respiration, very common, benign. Incomplete RBBB, RSR, pattern V1 without prolonged QRS, common normal variant. Early repolarization, ST elevation at J point, especially inferior, lateral leads. Pathologic findings. Left axis deviation. AV canal defects, tricuspid atresia. Axis more negative than minus 30 degrees, infants, or minus 20 degrees, children. Left ventricular hypertrophy. Aortic stenosis, hypertension, cardiomyopathy. Tall R in V5, V6, deep S in V1, V2, strain pattern. Delta wave. Wolff-Parkinson-White syndrome. Short PR, slurred QRS upstroke, wide QRS. Prolonged QTC. Long-Court syndrome, medications, electrolytes. QTC greater than 460 milliseconds children, greater than 480 milliseconds infants. ST elevation. Myocarditis, pericarditis, Kawasaki disease. Diffuse or localized ST changes with clinical context. AV block 2 degrees or 3 degrees. Congenital, post-surgical, myocarditis, Lyme. Progressive PR prolongation or complete AV dissociation. Maintenance and quality assurance. Daily checks. Verify alarm settings appropriate for patient age, condition. Check electrode integrity and skin condition, change Q2448H or PRN. Inspect lead wires for damage or fraying. Confirm proper waveform quality and amplitude. Document rhythm strip per institutional policy. Equipment maintenance. Electrode storage. Keep sealed, store at room temperature, check expiration date. Lead wire care, coil loosely when not in use, avoid kinking, clean per manufacturer guidelines. Monitor calibration, biomedical engineering verification per schedule, typically annually. Battery maintenance, for transport monitors, charge regularly, test battery life. Documentation requirements. Initial application, date, time, lead configuration, baseline rhythm, rate, intervals. Rhythm strips, store significant arrhythmias, pre-post intervention, per policy. Alarm events, document cause, patient status, interventions. Electrode changes, node site rotation, skin integrity. Artifact issues, document troubleshooting steps taken. Safety considerations. Warning safety alerts. MRI compatibility. Remove all standard ECG electrodes and cables before MRI. Use MRI-compatible monitoring only. Defibrillation. Modern electrodes are defibrillation safe, but ensure no gel bridges between electrodes. Electrical safety. Ensure proper grounding, use hospital-grade plugs, inspect for damaged cords. Skin integrity. Monitor for adhesive reactions, especially in neonates with fragile skin. Alarm fatigue. Set age-appropriate parameters, minimize false alarms, respond promptly to true alarms.